everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles and Sharsheret. I'm Kathy Riley, the Associate Director of Programs at Cancer Support Community Los Angeles, and I'm really honored to welcome you to this collaborative webinar titled Cancer Genetics, How Do You Wear Your Genes? And before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization that provides vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. And our support groups include, or our programs include support groups and healthy lifestyle classes, social activities, and educational programs like this one. And if you want to learn more about our services or watch past webinars, you can visit our website at cancersupportla.org. And before I introduce Jessica Jablon from Sharsheret, please note that your video and microphone are automatically disabled for this webinar. You can enter questions into the Q&A feature that's found at the bottom of your Zoom window, and please enter them throughout the webinar. We may not be able to get to all your questions today, but we'll get to as many as possible. The chat feature is also open. Feel free to share comments and resources with other participants, or you can ask questions of CSELA and Sharsheret there as well. And limit the chat comments to information relevant to this topic. And I now want to welcome Jessica Jablon, the Director of the West Region for Sharsheret. Welcome, Jessica.
Thank you, Kathy, and thank you to Cancer Support Community Los Angeles for having us here today. You guys are wonderful partners, and we're just so excited to be here. Before I begin, I just want to share a little bit about Sharsheret with you. Sharsheret means chain in Hebrew, and we are a Jewish not-for-profit organization that provides free virtual personalized support, life-saving education, financial assistance for non-medical needs, and genetic counseling to empower those of all backgrounds faced with or at increased risk of breast cancer and ovarian cancer. Our social workers and genetic counselors are here to help you navigate the cancer journey before, during, and after diagnosis with free support and resources, including caregiver support, free kits that we send out in the mail, like our Busy Box for families with young children, that comes with toys and resources on talking to your kids about your diagnosis, and our Thriving Again kit, which is our survivorship kit that comes with a cookbook and exercise bands and more. We also do a tremendous amount of webinars that can be found on our website at sharsheret.org. I know Kathy will be posting my contact information on our website at the conclusion of today's program, so feel free to reach out. As we move into the program itself, I'd like to remind you that the information provided by Sharsheret is not a substitute for medical advice or treatment for specific medical conditions. You should not use this information to diagnose or treat a health problem. If you have questions that are specific to your medical care, we recommend that you speak directly to your medical provider. Before we begin the panel, I'd like to introduce one of our incredible Community Advisory Committee members, Elisa, who is going to share her personal story with you.
All right. Hi, everybody. They say knowledge is power, but I've learned that support is everything. I'm truly so happy to be here today to share something deeply personal, something I didn't always feel ready to talk about. When Jessica called and asked if I'd speak, I said yes without a second thought. But the moment I hung up the phone, I thought to myself, wait, did I really just agree to this? But the truth is I wanted to. Because if sharing my BRCA journey helps even one person feel less alone, then it's worth every moment. My mother passed away almost 35 years ago from breast cancer. That loss has never left me. Back then, the BRCA gene was only starting to be understood, but I knew I needed answers. I took the genetic test out of pocket, no insurance. Hang on. I took the genetic test out of pocket, no insurance, because if you were BRCA positive, you risk being denied coverage altogether. Years later, I was introduced to Sharsheret. an organization that quickly became a guiding light. In 2018, I had updated testing at Cedars. The result, a variant of unknown significance, or VUS, on BRCA2. Basically, they told me, we're not sure, but we'll keep an eye on it. I was fortunate to connect with Peggy, a genetic counselor at Charcheret. She helped guide me through this strange and uncertain territory. She brought clarity, and more importantly, she reminded me that I wasn't alone. From time to time, I check in with her, always seeking that next bit of reassurance, that sense of direction. Then, 5 years later, I got that call. My variant had been reclassified. I was now officially BRCA2 positive. I was stunned. The first person I called, Jenna Fields at Charcheret, and she knew. She understood exactly what I was feeling. She showed up the next day just to give me a hug and a beautiful Charcheret robe. That small gesture meant everything. In November of 2023, I made the decision to move forward with prophylactic surgery. It wasn't an easy choice, and the road to recovery, it was long, it was challenging. But it was a decision I made thoughtfully and on my terms. And through it all, I was surrounded by the most incredible support from my husband, my children, my family, my closest friends, from the care packages, the messages, the check-ins, to the strength of the Charcheret community. I never walked this path alone. In the beginning, I kept my journey private, quiet. But during a Charcheret advisory board meeting at my home, something shifted. I found my voice, I spoke my truth, and it felt right, and it felt necessary. Now I'm proud to be a Charcheret peer supporter, walking alongside others as they navigate similar paths, because I know how powerful connection can be. We've come so far in understanding genetics, but no one should have to face this alone. That's why Charcheret is so vital. It's not just about medical answers, it's about emotional support, empowerment, community. And if there's one message I want to leave you with today, it's this: support matters more than fearlessness. And I am so deeply grateful to Charcheret for giving me that support when I needed it most. Thank you all.
Thank you, Elisa. We're so, lucky to have you involved with Charcheret, and we're so grateful that you shared your story with us today, and that you have been sharing it in the community, because it really does impact other people's journeys, and we're just so grateful. So thank you for being here. Now I'm honored to introduce our esteemed panelists. Ilana Solomon is the Deputy Director of the Center for Precision Medicine and a licensed board-certified genetic counselor specializing in cancer genetics at City of Hope. Ilana joined the City of Hope Division of Clinical Cancer Genomics in 2013, where she provides cancer genetics services to patients and families with suspected hereditary predisposition. Since 2019, she also manages and develops City of Hope's Precision Medicine program with the goal of providing all City of Hope patients with genomic-driven care. Her research interests are focused on healthcare communication and implementation, genetic literacy, and ethical, legal, and social implications in genomics. She helped co-develop Helping Oncology Patients Explore Genomics, a patient-directed IT platform for cancer genome sequencing, education, and return of results. And Dr. Sabrina Hardy, who is an assistant professor in the Department of Medical Oncology and Therapeutics Research at City of Hope, Thousand Oaks and Simi Valley. Dr. Hardy takes a compassionate approach to cancer care, educating patients about their options, making collaborative decisions, and employing innovative therapies to craft personalized treatment plans. Inspired to become an oncologist by her mother's battle with breast cancer, Dr. Hardy finds it particularly rewarding to build long-term relationships with her patients and their loved ones. After attending medical school at Poznan University of Medical Sciences in Poland, Dr. Hardy completed an internal medicine residency at the University of Alabama at Birmingham, where she was recognized as most academic resident. She then completed a 3-year hematology oncology fellowship at the Medical College of Georgia in Augusta. I'm going to ask some questions, and then I know we did receive quite a few questions in advance, and we'll see how many we have time to get to. But I'm going to start off with a couple of questions, and I know Dr. Hardy has a presentation for us as well. So, Ilana and Dr. Hardy, is a question for both of you. When you're talking to a new patient and you're asking about their family health history, what are you looking for?
Should I go first?
Ilana,
Yeah,
sure.
sure. I'm doing typically a cancer focused family history. So I'm looking for kinds of cancers that happen, age of onset, patterns of cancers on both the maternal and paternal side, as well as cancer screening history and health history. But it is a cancer, at least in the City of Hope setting, I'm really doing a cancer focused family tree.
Dr. Hardy?
Thank you for so much again for being here and for inviting me. So yeah, there's a couple of things that I look for. Age of onset, the type of cancer diagnoses. I ask about family history and trying to link, what types of cancers are in the family, since we can group some of the different cancer types into, a possibility for a specific mutation. I think about the location of the tumor sites. Are there multiple tumor sites involved? And multiple cancers in one patient. So a lot of different factors pop up in my mind about asking. And then again, family history. When it comes to the family history, again, I think about different types of cancers, so prostate, ovarian, pancreatic, and breast cancer, and to know the different patterns of inheritance as well.
Thank you. Ilana, Sharsheret is a Jewish organization, although we help everybody regardless of background. But one of the things that we are experts in, of course, is the BRCA mutation because of the increased risk in the Jewish population. Can you talk about the risk for being a BRCA carrier in the Ashkenazi population?
Sure.
Thank
Yeah,
you.
so that is a great question. So we know having a mutation in one of the BRCA genes is usually across the board about 1 in 400. But for people of Ashkenazi Jewish ancestry, it's about 1 in 40. And that's due to a few founder mutations. So these are gene changes that arose in Ashkenazi Jewish historic populations. And then for several reasons, including, populations that were not intermingling, the Holocaust, and several other times that the population was actually decreased in size. Those mutations just kind of increased in prevalence. And so because of that, people who, first of all, we always ask about Ashkenazi Jewish ancestry. And second of all, our threshold for testing people for BRCA1 and 2 mutations is much lower because we know that anybody with that background has a higher chance of carrying a mutation. And so that's the reason why that it's a higher prevalence.
And can you just talk a little bit about how BRCA and other mutations run in families?
Sure. Would you like me to handle that one?
Yeah.
Okay. BRCA1 and 2 mutations. So I think of them as they are tumor suppressor genes. So they are genes that help us protect us against developing cancer. And we all have 2 copies of those genes in our body because we get one from our mom and one from our dad. So if somebody has a BRCA1, they're called mutations or BRCA1 positive or BRCA2 positive. That means one of their 2 is not working right. So that means every time they had a child, they could pass on one copy 50% of the time and another copy 50% of the time. That is called dominant inheritance. And so what it might look like in a family is that several generations are impacted. So you'll take history from both the mom and the dad side. And so something to consider when thinking about a family is that the risk of getting cancer for BRCA1, BRCA2, as well as most of the genes associated with inherited risk, is not 100%. So somebody can inherit a BRCA mutation and never develop cancer. About 1 in 5 women will never have any cancers associated with that. So it can look like it might be skipping generations or skipping around, but in fact, it is a 50-50 chance that a BRCA carrier passes on that mutation to their children.
Thank you. And just one more question for you. How is genetic testing performed? And what age do you recommend people undergo genetic testing?
Great question. So genetic testing is pretty straightforward. It can be a blood test, or it can be a saliva test, or a buccal, which is just a cheek swab that we can send to patient's house, and then they send back to the lab. And they also, many labs have the mobile phlebotomy option, so actually a lab can come to people's house and take a blood sample. The testing is performed in the lab. It takes about anywhere from 2 to 4 weeks to come back. That's basically how it's performed. And then a report is generated that's shared with the patient.
Can oh, sorry.
No, go ahead, please.
I was going to say, can you talk a little bit about the role of a genetic counselor?
Sure. So genetic counselors are basically here to guide patients and their families, because we work with families through the genetic testing process. So there is pre-test counseling where we'll go through a very detailed family tree. We'll talk about the genetic testing process, do an assessment and take into account risk factors, and then come up with a plan for genetic testing. What is genetic testing? What are the options? What is the recommendation in terms of the kinds of panels of genes? Because now we typically offer panels of genes, and then go through the informed consent process so the patient understands what genetic testing is and how the information could impact them and their family in the future. We're also there to provide psychosocial support. So we are counselors, and so dealing with a cancer diagnosis and the implications of that, as well as the implications of having an inherited form of cancer. We're there to support the patient and their family through that.
Thank you. That actually brought up one more question. Can you just talk a little bit about a medical grade test versus recreational testing?
Yes. So there are lots of genetic tests out there, and there are clinically graded tests, and then there are tests that I consider exactly like you would say, more recreational. Um, we always order clinical grade tests so we can be certain that the results we're getting are accurate. And typically, many of the recreational ones can be ordered directly they're not mediated by a provider. So there's no genetics doctor or genetic counselor sort of ordering. And they could be really useful to people. People use recreational or other kinds of genetic tests all the time. My firm recommendation as a genetic counselor is that if you have concerns about any genetic risk running in your family, that you meet with a genetic counselor to make sure that the testing that's ordered is thorough, is correct, because unfortunately there are scenarios where I see patients and they have false reassurance because they think, oh, I got this genetic test, online, and it turns out that test missed mutations or was inaccurate, and they actually need more testing or more screening.
Thank you. Dr. Hardy, I know you have a presentation that you wanted to share with everyone.
Let me just share my screen. All right. Can everyone see that?
Yes.
Yes, okay. And Ilana, if you want to jump in and chime into anything, please do. All right. So, my first slide is what causes mutations, and what are some of the factors that can really lead to cancer. So exposures, so this could be environmental, lifestyle associated exposures. This is where I talk about, perhaps what kind of a career a patient may have had, or what did they do for a living, or early exposures, did you serve in the military? So exposures to something like asbestos or even Agent Orange, and perhaps that link with certain leukemias or any hematologic malignancies. So those are all questions I do like to ask. Of course, there's always inherited genetics, which I'll talk about later on. And then also things that are influenced by lifestyle choices, chronic inflammation, age can also cause acquired accumulation of mutations and changes in the cellular processes, which can increase cancer risk. So all of these things can lead to someone having cancer. So thinking about, what are your chances? So only a minority of cancers are actually hereditary. So 5 to 10% of cancers are hereditary due to a genetic mutation. We notice a clear pattern of inheritance across generations. 90% of cancers are sporadic. Again, this is due to environmental exposures, age, perhaps. In the middle, we have about 10% where we may see clustering of family members, but without a clear kind of pattern. And those are usually patients with some kind of genetic mutation, perhaps with some environmental factors that definitely increase the risk of cancer. So what do I look at? It's early age of onset. So any patient that had cancer diagnosed at the age of, 20, 30, perhaps in the early 40s age is when I think about hereditary cancers. I think about multiple family members being affected, bilateral cancers, multiple primaries. So patients that may have had breast cancer with pancreatic cancer or renal cell carcinoma, so kidney cancer, where it's presented in both of the kidneys, for instance. Associated cancers, again, those are patterns. So if I see a lot of family with breast cancers, ovarian cancers, prostate cancers, those are all indications of possible hereditary mutations. Now, unusual presentations as well. And then again, this is autosomal dominant. Here's a little kind of a picture. So if one parent is affected with a mutated gene, then each child has a 50% chance of inheriting it and expressing that trait. So in particularly in breast cancer, I think about a hereditary mutation if a breast cancer diagnosis was at the age of less than 50. I think about it in multiple primary cancers, male breast cancer in particular, and all triple negative breast cancer patients as well. And then multiple blood relatives with breast cancer, again, usually 3 or more blood relatives with patterns of the cancers, so prostate, ovarian, pancreas, and then breast cancer also in the Ashkenazi Jewish ancestry that we talked about. So why would someone want to pursue genetic testing? Well, it's to understand why a cancer occurred. It may aid us in decision making regarding potential surgery. We may be able to provide information about future cancer risks, and then how do we monitor patients and their family members, and what are the conversations like for risk reducing surgeries. So many breast oncologists and surgeons, we may order a BRCA1 and 2 mutation urgently in order to make a thorough decision if we want to proceed, for instance, with bilateral mastectomies prophylactically up front rather than just doing a unilateral mastectomy or lumpectomy, since patients with BRCA1/2 mutations may be at higher risk. So these are all conversations that we have and testing that we can do up front to make those kinds of decisions for with patients. Now, it may also help other family members learn about their cancer risks, and then access to clinical trials or specific cancer therapies as well. For instance, BRCA1/2 mutations can be very helpful in the prostate cancer setting, ovarian cancer, breast cancer setting, as now we have PARP inhibitors that we can offer to patients that may help decrease the risk of recurrences. So Just briefly, again, there's many options for genetic testing. If the level of cancer risk is high, moderate or multi-gene panels should be considered. And good history taking with family history, personal history may help us decide which one would be better for us. If that's many genes tested all at once or just a single gene initially, many tests may be many genes can be tested on these multi-gene panels, and they have about 70 or more genes that we test. And the single genes, perhaps maybe we can just test for BRCA1 and 2, especially up front if we need to make a urgent decision about what kind of surgery we would like to do. So the genetic testing results, they will come out as pathogenic, likely pathogenic, variant of unknown significance, or a VUS, likely benign or benign. And so VUS are alterations in the genetic code, which will impact protein function, is uncertain. So VUSs are common. They're usually more common in those large multi-gene panels. Now, what's important about VUSs is that they're usually reclassified. So about 90% are actually reclassified as benign. Some of them can actually become pathogenic. So it's advisable that in patients that get these multi-gene testing, to reach out to our genetics team about every 3 to 5 years, and for them to re-review some of these medical literature in regards to these VUS genetic results to see if perhaps this VUS now is considered a pathogenic mutation.
Dr. Hardy, do you mind if I jump in there?
Yeah.
Just like that was, a beautiful summary. And Elisa, just like in your case, you had an upgrade happen, which doesn't happen a majority of the time. So thank you for sharing your story. But that's why I think it's so important for individuals to get hooked into a genetics provider, because these genetics providers are going to make sure that they're getting the most updated test results. So if you do get a reclassification, whether it's an upgrade or a downgrade, that somebody reaches out to the patient and lets them know.
Thank you. So in breast cancer, we have the high-risk mutations, BRCA1 and 2. PALB2 is another one that we associate with breast cancer, and many different moderate risk, ATM, CHEK2, P10, TP53, CDH1, NF1. So these are all moderate to high risk mutations that, again, are identified through these multi-gene panels. So just briefly talking about BRCA1. So, what if someone were to have BRCA1, what is their risk? So with female breast cancers, we see up to 72% with this BRCA1 gene developing breast cancer by the age of 80. So this is why, having this information up front for the surgeon is important, because we could talk about bilateral prophylactic mastectomies. With ovarian cancer, we see this up to 48% by the age of 70. Male breast cancer is up to 1.2% by age 70. Prostate cancer up to 20%, and pancreatic cancer up to 10%. So if someone has, moderate to high risk, what do I do about this as a medical oncologist? So many guidelines recommend mammograms starting the age of 40 in the general population. So just keeping that in mind. Now, for patients that have high risk, I do like to do imaging more frequently, and this is done by breast MRIs as well as mammograms and ultrasounds. So typically I get MRI of the breasts on a yearly basis, as well as a mammogram and ultrasound on a yearly basis. That means that you're pretty much getting imaging every 6 months. So I do these images alternatively. I recommend starting at the age of 25 with breast MRIs, and then starting the age of 30 for mammograms and ultrasounds. Now, mammograms they're not the best for the younger population. So in younger patients, breasts are usually very dense. The mammograms may not find all masses or calcifications. That's why we add in the ultrasounds. Now, the radiologists have to note on the mammograms how dense breasts are. So I use that as also for more information to know perhaps we should add in an ultrasound or do an MRI of the breasts. And they will indicate on the report if they noted a dense breast, it's usually categorized as a C. So, additionally, we need to talk about prophylactic surgeries. So this is done with our breast surgeon. So talking about bilateral mastectomies, and then again, the risk reducing medications, which I will talk about here in a minute. So with BRCA1 gene mutations, we also worry about ovarian cancers. So doing a salpingo-oophorectomy and hysterectomy by the age of 35, 40 years of age should be discussed. And then for male breast cancers, we encourage clinical breast exams, self breast exams, and then perhaps mammograms if the patient has enough tissue in order for us to do that. Just wanted to briefly bring this up. This is just a chart summarizing the radiation exposure, and I do experience a lot of patients worried about the exposure to all this radiation, and we typically use that 50 MSV as kind of the annual limit. So we don't want any more than that in a year. And so if you look, mammograms have perhaps just maybe 1 or 2 MSV. So if we're doing this every 6 months or even a year, the radiation dose is very little. So here is a big chart, pretty busy, just briefly talking about the breast cancer risk reduction. So I do have patients coming into my clinic. We talk about, can we use any medicines to help lower that risk of developing breast cancer? And so risk reducing agents like tamoxifen, like raloxifene, or aromatase inhibitors and anastrozole may be recommended in individuals that are older than 35 years of age, that have a Gale model 5-year breast cancer risk over 1.7% or a Tyrer-Cuzick risk of over 5%. So for patients with BRCA1 or 2 gene mutations who do not have a diagnosis of breast cancer, reducing medications may be considered for breast cancer prevention, although some evidence comes from studies in high-risk women rather than BRCA carriers specifically. And so really, this isn't a conversation all patients should have with their oncologists. At this time, the best medical prevention option, though, still remains as surgery, and risk-reducing surgeries like mastectomies and salpingo-oophorectomies are the most effective prevention strategy.
And Dr. Hardy,
So
would
also,
you, oh, sorry.
yeah, go ahead.
I was just going to add also that I think this is a very, important discussion to have with your doctor about the best strategy to reduce your risk. I'll just add that when you see those are risks over a lifetime, right? So something that you always have to think about is, what is the age of the person? They get credit for time served. So have they lived through some of that risk already? And what's the remainder risk? So I think that's something that every person who's thinking about what decision to make and how to sort of handle their risk needs to think about it in a way where you're thinking about it over time and not just as, oh, I'm just facing this entire risk all at once. And that's what we try to do with our risk assessment process, is really try to think through, those nuances.
Thank you. And then, of course, lifestyle modification. So alcohol consumption, a lot of patients ask me, well, what does that mean? So the guidelines really say no more than 3 drinks a week. And then exercise, as well as maintaining a good, healthy weight. So sometimes we can use PARP inhibitors in the treatment of a lot of our cancers. So in the metastatic setting, results from genetic testing may have therapeutic implications. So germline mutations in BRCA1 and 2 have shown utility. Germline BRCA1 2 mutations should be assessed in all patients, especially in our recurrent or metastatic breast cancer patients, to see if they could potentially be candidates for PARP inhibitors such as olaparib. And this is all, guideline. These guidelines are based off of clinical trials. So the big clinical trial that we follow is called Olympiad trial, where metastatic breast cancer harboring this germline BRCA mutation, patients were being compared with PARP inhibitors to chemotherapy, and they noted improvements in progression-free survival. So the time before a patient has progressed, and they've noted that the patients receiving PARP inhibitors with olaparib did better than conventional chemotherapy. And this was more particularly seen in our triple negative breast cancer patients. So this also is a big factor in our treatment planning as oncologists too. And I just wanted to briefly talk about germline testing and somatic tumor testing, because there's a lot of questions that I get from patients about these two. So somatic mutations are genetic alterations that are not germline. So they are not they're not mutations that occur, in the sperm or egg cells. They're acquired through a person's lifetime in single cells, which led to cancer. So they're not inherited. They only occur in the tumor itself. Whereas in germline mutations, it's inherited, and these are the ones that cause family cancer syndromes. They are present in the egg and sperm. So tumor tissue biopsies are really done to look for somatic mutations. And that's when, your oncologist may say, we're going to repeat the biopsy, we're going to send for next gene sequencing. This is just information for us to potentially have another discussion about FDA approved therapeutics for any possible mutation that we are able to identify from that tumor testing. And for instance, for BRCA mutations, most BRCA mutations are germline mutations, and sometimes somatic BRCA mutations can occur. They're not as common, about 3%. But again, these are the differences between the two tests. There's a lot of risk assessment models that patients can do at home with themselves. I do this risk assessment model. My breast surgeon that I work with at the clinic also uses this risk assessment model. So there's a lot of different models available. I think the most common one is the Tyrer-Cuzick risk assessment model, and it's there's been a lot of studies looking at which model is better, more accurate. None of the models are actually perfect, but it can help guide our evaluating a patient's risk of developing breast cancer over their lifetime. So this is available online. There are some limitations, like they don't ask about any history of radiation, but it does ask about age, family history, race, breast density, prior breast biopsies, hormone exposure, age of menopause or age of menses, childbirth history. And so the average risk of women in the United States over their lifetime is about 13%. So right now you can say 1 in every 8 women will develop breast cancer. And so for us, when I think about a patient with a high risk of breast cancer in their lifetime, those are usually those that have a 20% or higher risk of developing breast cancer by this model. So 1 in 5 risk or greater. And so that's when I perhaps may talk to patients about doing more frequent scans, alternating MRI breasts versus mammograms. So what happens if you've already been tested? Well, you're still eligible to meet with a genetic counselor if your previous testing was uninformative. Again, if the test was negative or has a VUS, then perhaps you can still talk with a genetic counselor to see if that VUS now is pathogenic or not. Sometimes these tests may be outdated, so I think it's maybe recommended that if you've had a genetic testing done perhaps maybe 10, 15 years ago, there may be a talk about repeating it. I don't know if Ilana, if you have more information about that, but I think repeating genetic panel after about, if it's been done 15 years or even older than that, there may be some consideration to repeat it.
Definitely. I would say genetic testing panels are changing pretty rapidly. We're learning a lot about new genes available. So I would say definitely if you've had your testing, 10, 15 years ago, you would qualify for update testing where the testing that was done was probably, good for the time. But since then, we have different ways of looking at genes and more genes to test. So we encourage everybody who has testing, as you mentioned, Dr. Hardy, to reach back every 3 or 5 years, just because we're learning more and we're able to test, and the cost of testing has gone down really quickly. So
Yeah, and so I get a lot of questions about like, will my insurance cover it? And usually if NCCN, there's the guidelines are met, then yes, they should be able to cover it. And if they don't, it's not that expensive. I mean, relatively, the panels are usually around $250, $300, if I'm not mistaken.
yeah, and labs have really good patient assistance programs that are really robust. So honestly, most of my patients don't pay anything for genetic testing, and at most exactly 250 to 300. And even if a patient does not meet the NCCN coverage guidelines, so that's what typically insurances will say under these certain scenarios you should cover genetic testing, and that's usually what insurances will use as a guidepost. But I will offer genetic testing to anybody. And really at City of Hope, we believe in universal testing. So if a patient is interested, even if they don't meet the threshold, we will try to get them tested.
Yep. And so, what do genetic counselors do? So, Alana will, talk to you about genetics, specific genetic conditions, the benefit, risks, and limitations of testing, how to interpret this information, and help provide information for, their families and me. So, thank you. That's all I have.
Well, thank you, Dr. Hardy. That was really, really informative, and I'm sure everybody learned, so much from your presentation. So, thank you for that. There were a couple of questions that came in regarding like what can genetic testing do for recurring cancers such as Hodgkin's lymphoma? I'm not sure if that's a question for you, Ilana, or for Dr. Hardy.
So I can speak to what's available right now. So we know a lot more about the genetics of solid tumors. So we've been learning about the genetics for breast cancer and colon cancer. And so the area of heme malignancies, which would include things like lymphoma and leukemias, there are genes available for inherited forms, just like there's inherited forms of breast cancer, there's inherited forms of any cancer. We're just less smart about what genes those are. I can't speak to like the recurrence related to the genetics, but I can say that if you have a personal or family history that is suggestive of inherited lymphoma or leukemia, then there are genetic panels available for those. But they're just not, we just know a little bit less because we've been testing people for a shorter period of time for those genes.
And I know Dr. Hardy had touched upon insurance a little bit. Is there a downside to getting genetic testing? Like, is there a reason you might not want to consider it, or are there things that you need to do in order to have um, genetic testing?
So I'm going to be biased here, of course, but I think that the benefits surely outweigh any risks. Patients come and they're often concerned about things like genetic discrimination. Without going into a ton of detail, there are federal laws. There's a GINA, which is the Non-Discrimination Act, which does not protect against, it protects against healthcare discrimination, but does not protect against long-term care or life insurance. But actually, California has its own state protections for life insurance. So there are concerns, but the benefits of getting that information and then getting the ability to either catch cancer early or prevent it altogether, in my view, is really such a big benefit. And again, not only to that person, but to their family members. Getting tested is informative for your family members. And what we can do in a counseling session is strategize who's the most important person in the family to get testing. How can we get them in for testing? If they live in another state, how do we get them tested, et cetera? So I see really, really high benefit to risk.
And I just want to do a plug for Share It. We do have genetic counselors on staff. So if there are questions about genetic counseling or whether or not you should think about genetic testing, feel free to connect with us, and we're happy to put you in contact with a genetic counselor. We don't actually do the testing or prescribe the testing. That's where like Ilana would come in or other genetic counselors. But for general questions, or if somebody that maybe you're diagnosed and your family member really would like to talk to a genetic counselor, Share It is there to be able to help with that as well. We've been hearing more and more about things like PGT or pre-implantation genetic testing. Can one of you speak to that? Or maybe Dr. Hardy, is that a question for you?
I honestly I don't have a lot of knowledge on that. So
I can speak to it. PGD is it's called pre-implantation genetic diagnosis. And so some individuals who find out they're at risk for inherited cancers, whether it's BRCA or another gene, feel that they do not want to pass that on to future generations. And so they will meet with a reproductive specialist. It's an IVF process, and they basically don't implant the positive patients. And so that is, it usually requires resources to go through that process. And there are families that works really well for, and families that say, listen, we know this information ahead of time, we can keep people cancer free. And so they decide not to go through that. But it is a technology that's available, and there is uptake amongst people of various cancer syndromes.
Thank you. There's a question in the chat about if high apolipoprotein A has an effect on breast cancer.
So I'll let Dr. Hardy weigh in, but to my knowledge, that's the ApoE gene. So that is the gene that there are several variations of that gene that have been shown to increase somebody's risk to Alzheimer's. I'm not aware of any association or any confirmed, risk association between the two, but I'll defer to Dr. Hardy if she's aware of any.
yeah, I know that they were looking into it and for cognitive CNS type diseases like Alzheimer's, but I think there were some studies looking at it, and perhaps maybe as a marker for risk or prognosis. I think that there's some role in like lipid metabolism, maybe some form of immune system regulation. But as of now, I don't believe that there's any role that is established in using this in breast cancer management. But perhaps there's studies that are looking into it. I'm just not well versed in that.
Thank you. Lana, when people leave here today and they're eager to speak to a genetic counselor, do you have a recommendation for a good place to start?
So I will say that we'd be more than happy to see you at City of Hope. Share It obviously has genetic counselors as well. You can go to findageneticcounselor.org, and you can actually look to see what's available to you. I will also add that many counseling services can be done remotely. Genetics has lent itself really naturally to remote work. So that's really great for patients because it doesn't require they schlep across town to go see a genetic counselor in person. And we here at City of Hope do provide a lot of our services remotely. And Jessica, do you mind if I just answer one more question that I realized I didn't answer from the beginning about the age for testing?
Yeah.
So there really is no, so there was a comment, I think I saw a question earlier about sort of age of which you start screening. Really, we don't test anybody under 18, and we don't do anything differently for BRCA1 and 2 carriers until they're 25, unless there's an extreme presentation in the family where there's super young cancers. So we wait until somebody's an adult so they can decide and make an autonomous decision about their genetic testing. And then it just depends on the person, sort of where they are, and if they're you know, psychosocially ready for that information. We believe it's in genetics, unless there's a risk for children, we don't typically test children. We wait till they're adults, and then we usually work with the person and decide, at 18, should we wait till you're done with college? Like, we just try to get it done before we would change their care if they were positive.
The one question that came in was, for a survivor of breast cancer, is it important to have genetic testing done for breast cancer? What specific ones? So I think we get that question a lot. Like, I had breast cancer, for whatever reason, there wasn't testing during the process of being diagnosed. Maybe it was a long time ago. Is that something that they should consider getting now?
I would say definitely, because it will inform us about future cancer risks. So Dr. Hardy had summarized it there. For instance, with BRCA1 and 2, there are risks for ovarian cancer. There can be risks if you've had breast cancer to have a risk of another breast cancer that would warrant increased screening. So that is a question that comes up all the time. Ilana, I've already had cancer. Why do I need this test? But the truth is that A, it can still help inform us about how to take care of you better moving forward. And B, it's still information that's helpful for your family members.
Thank you. And I think, just for the final question, is there something specific that each of you hope everyone will take away from this discussion?
I would just say I hope that this has increased your knowledge about genetic testing, and that I think it's a great tool. And I hope you all feel empowered to explore it if it's something you're interested in. And I hope that this has been helpful in that regard.
Yeah, same. So, I think it's an important part of medical decision making, and also really decreasing the risk of another type of cancer in our patient population. So, these are discussions that are questions you should ask your primary care provider, or if you're seeing an oncologist still, your team to help with your family and your kids, and making sure that everyone is getting screening so we can catch the cancers early if they do occur. And so I hope that this was informative and helpful, and thank you again.
Oh, thank you. So I just want to, say thank you to Dr. Hardy. Thank you to Ilana. Thank you to Elisa. I know I always learn something new when I'm doing these presentations, and, we're just so grateful for you to spend your time, educating the community. And again, thank you to Kathy and Cancer Support Community for letting Share help provide this webinar.
And I want to extend my thanks to you, Jessica and Sharsheret, for just creating this wonderful space for us to talk personally and educationally, and just so in depth about this topic. And thank you, Dr. Hardy. Thank you, Ilana. Thank you, Elisa, for sharing your story. What a rich hour this has been. So thanks to each of you. We have a closing slide that we're going to share. And I want to thank all of you for joining us today, all of you who have viewed this webinar, and for your engagement with us today. If you want to learn more about Cancer Support Community Los Angeles, you can visit our website. If you have questions for CSCLA, you can email us at info@cancersupportla.org. And then if you would like to learn more about Sharsheret or their programs, you can visit their website listed here. And if you have any specific questions from today or about Sharsheret programs, feel free to email Jessica, and her email is here. And this is the part where we say goodbye to everyone, and thank you so much for your time and spending this hour with us. Take care, everyone, and hope to see you soon at another educational event.